All right. So MCN quickly pulled together this webinar to share critical information in response to the ongoing outbreak of cyclosporiasis. And knowing that the parasite that causes this illness is unusual and hard to detect, it requires special laboratory capacity, and few community health center staff would likely have had much experience with this condition. We reached out to the Michigan Department of Health and Human Services that has detected the largest number of cases so far in this outbreak. And we're lucky to able to get to their chief medical executive, Dr. Natasha Bagdasarian, as well as our incoming chief medical officer, Dr. Ava Galvez, to bring the community health center perspective. Next slide, please. Do a
Yes.
quick round of introductions.
Just a reminder to speak a little slower for
Thank you.
session.
Thank you. Dr. Bagdasarian is the Chief Medical Executive for the state of Michigan. She is board certified by the American Board of Internal Medicine in internal medicine and infectious diseases, and is a fellow of the Infectious Diseases Society of America and the American College of Physicians. Dr. Bagdasarian completed medical school at Wayne State University, internal medicine residency at the Infectious Disease Fellowship at the University of Michigan. She received a Master of Public Health from the University of Michigan School of Public Health, where she now serves as adjunct faculty. She is a member of Governor Gretchen Whitmer's cabinet. She chairs Michigan's Public Health Advisory Council, Gun Violence Prevention Task Force, and the Opioid Task Force. We also have with us today Dr. Ava Galvez. She's a board certified family physician and healthcare leader with over 16 years of experience providing comprehensive primary care in federally qualified community health centers. Throughout her career, she's focused on caring for immigrants, migrant and seasonal farm workers, and other communities facing significant barriers to health care. She's the proud daughter of former migrant and seasonal farm workers. Dr. Galvez brings a deeply personal understanding of the social, economic, and cultural factors that influence health outcomes and has presented nationally on health disparities and social determinants of health. She has provided policy leadership and legislative testimony on issues including farm worker rights, immigrant health coverage, environmental health, and COVID-19. She serves as Oregon Health Sciences University affiliate faculty, and starting next month, she will begin as Chief Medical Officer here at MCN. And I am Renee Edwards. I'm your moderator for today. I'm the Director of Training and Technical Assistance at Migrant Clinicians Network. My background includes working at local, state, and national public health agencies in infectious disease prevention, control, and surveillance, including outbreak investigations like cyclosporiasis. Could we run poll number 1? We have a quick poll for the audience. People could take a moment before this large outbreak. Had you ever heard of cyclosporiasis?
Now, Renee, I don't know if you can see our results, but we have about 86 people
Okay,
that have answered so far.
okay. Go ahead and let us see where we're at with that.
Okay. I'm gonna end the poll, and we're going to share the results.
Okay, that's what I thought, that this is an unusual situation that we're having for sure.
Okay.
All right, next slide, please. All right, our learning objectives for today are to describe the participants, when they're done here, can describe the current cyclosporiasis outbreak and what distinguishes cyclosporiasis from other diarrheal illnesses. Describe how health centers can collaborate with state and local health departments. Recognize the risks and barriers for migrant, immigrant, seasonal agricultural, and food service workers that they may face during an outbreak like this. And provide prevention messaging recommendations while the food source has not been fully confirmed at this time. Next slide. All right. Cyclosporiasis is not like other gastrointestinal illnesses. It's not a bacteria or a virus, and it's not easily killed or washed off through standard food hygiene practices. It's even hard to just say the word. Next slide. Cyclospora cayetanensis is a protozoa. That is, it's a type of parasite with a special life cycle that makes it hard to detect and kill in the food chain. People don't get infected with actual live protozoa, but instead with its oocyst, or an egg-like structure that is released in the stool or poop of infected humans. It then has to live for a few days to weeks in the environment, potentially contaminating water systems, fields, and food processing equipment. You do not get it person to person directly. Once people eat something contaminated with cyclospora, the oocyst opens and releases the parasite into the person's gastrointestinal system, taking a few days to a couple of weeks before they actually get sick. Humans are the only host and reservoir of cyclospora. It's not spread by pets, livestock, or wildlife. It only infects humans. It's only humans that can contaminate water, food, or food processing equipment. Again, it has to go through this whole process of being released in the environment or the water system and then rest in the environment for a while before it can infect people. I can't just make you a salad with my unwashed and fecally contaminated hands and infect you directly. That can happen with bacteria and viruses, but not cyclospora. Next slide. As mentioned, it takes from 2 to 14 days and usually about a week after eating something contaminated or drinking contaminated water to start having symptoms. People tend to have 6 or more watery diarrheas a day that can be very urgent or explosive, as the media has enjoyed saying. But just because someone does not report explosive diarrhea does not mean they do not have it. Other symptoms can include anorexia or not feeling hungry, fatigue, not feeling tired, abdominal cramps, bloating, nausea, and as a result, patients may lose weight and become dehydrated. Some may have a low-grade fever. So dehydration really is the main medical concern, and we want to be especially concerned for young children or elderly who may become sick with this. And another unusual and sort of telltale sign of cyclospora is that it may stop and then start back up on and off for weeks or even months if it's left untreated. This is often what makes people finally go to the doctor. All right, next slide. All right, so unfortunately, it's not easy to test for either. Not all labs are able to test for it, and it's not part of the standard ova and parasite panel. Clinicians must specifically request that the lab they work with include cyclospora in their order. PCR-based gastrointestinal multiplex panels, that is preferred test. And again, confirm that your lab is able to test for cyclospora and that your order specifically includes the request to include cyclospora. Another option is microscopy using acid-fast staining, again, specifying cyclospora in your order. Patients will need to collect and submit multiple samples. Because oocyst shedding can be low and intermittent, it's hard to find. You got to give your patients collection tubes then for at least 3 samples and materials, any other materials they might need, and that they understand that they need to do it on 3 consecutive days. So they can't collect all 3 samples on one day. Be sure they understand that. And make sure then that you have 3 orders to go with the 3 samples. Now, some local health departments might be able to help you prepare for this or give you some advice on managing collection materials. If you're unsure, I really recommend for community health center staff to give your neighborhood, your local or state health department a call so that you can be in touch with them and start building that relationship if you haven't already. They are your friends. All right, next slide. We're almost done here with slides and we can get to our speakers. All right, there is some good news. Cyclosporiasis is treatable and symptoms will end quickly once a person gets going with treatment. We have, at least one particular medication that we want to use for this, trimethoprim sulfamethoxazole or TMP SMX. We want to use the double strength tablet. For first line, you're going to take it twice a day for 7 days. If you have immune compromised patients, it's going to be a bigger dose for 10 days. And then you're probably going to want to be giving them secondary prophylaxis for at least a few weeks. Again, depending on their health, their conditions, you'll have to really see what's going on with that person. There is an option for sulfa intolerant patients, and that's ciprofloxacin, right? So make sure that you're sticking with one of those two drugs and not other things that you might think works with other conditions. Next slide. All right, quick map. This is the most recent map I could find from a reliable source. And we can see where the states that are most affected remain, the same ones we've been seeing. Michigan has really been great at detecting the most cases. And so we'll probably continue to see this for a bit longer until this clears out. All right, let's close out the slides and start talking to our guests. All right, I'm going to start with you, Dr. Bagdasarian. What do clinicians need to know right now about the Southeast Michigan outbreak and the broader statewide and multi-state increase in cyclosporiasis cases?
Well, I think it's useful just to point out the sheer volume of cases that we're getting. So, in a typical year here in Michigan, we see between 40 and 50 cases of cyclosporiasis. And this year, just in these last 2 weeks, we have seen over 7,000 cases. So, for folks out there who are unsure how far this is from normal, this is really an unusual situation that's happening. So we continue to see those new cases come in. Just between yesterday and today, we've seen an additional 500 cases. Now, when we look at the Michigan data, and I don't have a view for the whole country, but I can tell you the Michigan data, what we are seeing is that there is a very clear signal around lettuce. And there has been a lot of talk in the media about places where people could have consumed this lettuce. People have talked about a fast food chain. And the thing is that we are seeing those kinds of signals, but we believe that this contaminated material was likely supplied to multiple different settings. So to fast food chains, to restaurants, and to grocery stores. And the product that we believe is highest risk is any sort of bagged lettuce or bagged salad greens. Because what happens is when there is contamination with cyclospora, it usually happens at the level of the field with water that's been used on that field or at the level where the lettuce has been washed and processed. And what can happen is that washing and processing step can actually amplify the contamination. So even if there are just a few heads of lettuce that have been contaminated, once they all go into the same baths to be washed together, once different pools of lettuce are combined when they go into the same machines, there can be a lot of cross contamination and that can amplify what happened. So likely there was contamination at a much upstream level than anything here in the state of Michigan, and that contaminated material likely went to different sources, to different types of venues, and that's why we're seeing this kind of pattern across the board. But one thing I will tell you is that it is possible that there's more than one thing going on. It's possible that this is not only lettuce, that this is something else as well, because about 12 to 13% of the people we've interviewed here in Michigan, and we've conducted 3,000 interviews, about 12% of them tell us that they have not been to a fast food restaurant and have not consumed lettuce in those 2 weeks before coming in. We also are hearing from other states that they're seeing different kinds of patterns. And so we really are saying that if you are someone with a weakened immune system, if you're someone who's pregnant, elderly, if you just want to be extra cautious, right now is a good time to be extra cautious around fresh produce in general. And with cyclospora, because it is so difficult to wash and it's so resistant to those typical washes, rewashing your bagged lettuce is not enough. So the safest way to consume lettuce, for example, is to buy a whole head rather than the pre-bagged lettuce and to remove the outer layers before you wash it and prepare it. And for other produce, if you are concerned, the safest way to consume other things is if you can peel it, peel it. If you can cook it, cook it. Those are the best ways to avoid cyclosporiasis. So just a little bit of a summary about what we're seeing here in Michigan.
Great. Thank you so much. Dr. Galvez, When should a clinician suspect cyclospora, and what are some common pitfalls in laboratory testing? We talked a little bit about that in the intro, but just thinking about folks who aren't used to thinking about things like this.
I think that's an excellent question because, we learn a lot about foodborne illnesses in medical school, the E. coli, the Salmonella, the Campylobacter, and it's important to point out that this is not a parasite that often comes to mind when we're thinking about foodborne illness, and so it's often not on a busy clinician's radar. So we need to keep that on our differential when we have a patient come into our clinic who's been having watery diarrhea, who's been experiencing nausea, vomiting, bloating, decreased hunger. Those are some of the symptoms that we really want to be looking out for. Now, I think it's important to point out that in a busy primary care practice, we might be dealing with other chronic medical issues, and then a patient might bring this up as an afterthought. So we really need to be able to be quick about thinking about this diagnosis. And then the tricky part is actually testing because we automatically think about sending out a stool sample in a busy clinic, and we have to remember that our standard stool test that we have in the clinic will not test for cyclospora, like you mentioned earlier. We really have to be very explicit and ask for that test. And again, it can be hard if it's not on your radar, or if you're in a busy clinic, you need to stop, step out, ask the lab to call the health department. And so there's some extra steps in doing so. So you can just see how that can become a barrier to getting tested. Um, yeah, so I think that's probably what I would say is the big thing is leads to being under, diagnosed and not frequently tested. So keeping that on the radar.
Yeah, and I will say, my own experience from living out of the country and coming home or having sick kids, like many clinicians aren't in the habit of getting stool samples. So that itself is something that people don't often regularly do. And in this case, it's necessary to confirm what's really going on.
Sure. And it's hard for patients to do, and sometimes they're not able to leave a stool sample in the clinic, and then they have to come back. And as many as you know, many of our patients have a hard time coming back into the clinic. So there's just
Right.
many barriers to the testing, and then confirming the diagnosis.
Thank you. All right, Dr. B, how might health departments support community health centers with laboratory testing or understanding what needs to happen?
Testing has been such a tricky situation during this outbreak, at least here in Michigan when we have so many cases. A couple of things that we have been hearing just for your awareness on this call is we've been hearing that there are health systems in our state that are running out of reagents because they are testing so many samples for Cyclospora. And we also are hearing that there are a lot of individuals who have symptoms, who have signs and symptoms of cyclosporiasis, who are declining testing because it's so expensive. So one of the multiplex tests that typically will detect cyclospora is the BioFire, and that costs about $427. And so for some folks, just that copay alone is very expensive. And so we have issued here in Michigan some guidance around empiric therapy with Bactrim, because we know that that cost can be prohibitive. I wish that there were ways that we could still that we could offer testing here at the state. Unfortunately, my state is one where our Bureau of Labs, they don't offer that multiplex test. They just have a specific cyclospora test. And so it's not the best for meeting a patient's clinical needs. But one of the things that at least my state lab is doing is we are doing some molecular and genetic testing of these cyclospora samples. So if you are in a state that is experiencing a high volume of cases, you can talk to your local or state health department and see if they are also doing molecular testing. And that helps us to link some of these cases and find out if they are in the same cluster. This is a difficult organism to do molecular testing on, so there are some limitations, but at least that's one step in our outbreak investigation. So if you're working in a clinic and someone is coming in, even if they cannot get the multiplex because it's cost prohibitive, it's possible that you still might be able to send those samples to your state lab, at least for that molecular testing.
Great. Thank you for sharing that. And I will say, as someone who has tried to reach patients during outbreak investigations, if you definitely have diagnosed your patient, or you think that that's the case, let them know ahead of time that the health department will call them so that they know what's going to happen, that it's okay. They're really just trying to understand and find out what the source is to prevent more cases. And especially if you have folks, who are farm workers or immigrants, letting them know that the health department is not interested in their status. And that's an irrelevant piece. They want to just make sure that they're finding out, who's eaten what, and stop the outbreak. It really helps if they know ahead of time. So I ask you all to, if you diagnose, please let them know what's going to happen. So speaking of, can we do poll number 2?
Yes. Launching now.
All right. Do most of you, or who all of our participants, have a copy of your state's required reportable diseases? Cyclospora is probably among them. It's probably a whole very large sheet of many, many things that we must report if we find it or diagnose it.
All right. We have reached over 50%, but we got some trickling in, Renee.
Okay.
I'll take this time to just remind y'all to speak slower. We do have interpreters. Y'all are doing great though. Just a friendly reminder. Okay, we got about 57%. I'm gonna end that poll. I'm gonna share the results. We're about 50
Okay.
50.
All right. Pretty good. I'm actually glad to see that many. Great, good going, folks. And for those of you who don't happen to, you can probably find it easily on your state health department's website. All right. Dr. Galvez, what unique considerations should clinicians keep in mind when caring for migrant, immigrant, or agricultural and food service workers during an outbreak like this?
So I think the first thing that comes to mind right now is fear of coming forward for testing, especially in the political environment that we've been in. I am seeing many patients, community members, just be really fearful of coming forward for any kind of, testing, healthcare, especially when there's a concern that a positive test might then end up in having a public health person coming into your home. I think there's a lot of vulnerability around that. People are fearful that being tested and being positive could certainly end up in their family being investigated. It could reveal documentation status, retaliation towards family members. So I think that's the big thing that we all need to keep in mind right now is that there may be fear just to come forward. The second thing is something that we have, as Migrant Clinician Network, talk about all the time that, even outside of this environment, there's always been multiple barriers for farm workers and immigrants accessing healthcare, right? So simply taking time off of work to go to the clinic is really difficult to do, especially if you're a farm worker and this is high season and missing work means that you may have a smaller paycheck at the end of the month, right? So those are the big things. Then, if you do come in for testing, first of all, you may not know where to go, especially if you're new to the community or you're maybe moving around. So you may not know where there's a trusted clinic. You may not have health insurance. You're afraid about farm workers and immigrants may be afraid about how much it's going to cost. And Dr. Bagdasarian just talked about how costly these tests are. So those are some major barriers that I foresee. I also think it's important just to understand that perhaps this is not on everybody's radar. And we're talking about how difficult it has been for even just clinicians that are on the ground to really have this front of mind as we're seeing patients. And so for some, our community members who are busy and are working, who may not be getting this information through usual communication channels, they may not even be aware that this is happening. And many of our patients often end up having symptoms that they can't explain. And so then they're trying to do home remedies. And then so they're dealing with these prolonged symptoms for a long time. So big barriers are just not simply being aware because lack of information and language that is appropriate or that the information is not culturally tailored to our communities. And then again, it's just the fear of testing and then barriers to accessing trusted healthcare.
Thank you. All right, Dr. Beeve, what should clinicians know about potential food handler restrictions, return to work requirements, and how these may vary? But the laws could vary state by state.
In general, because as you mentioned early on, cyclospora is not something that is typically transmitted from person to person. In general, and at least here in Michigan, there is no specific guidance about return to work around cyclosporiasis. But in general, what we are advising clinicians is that if you're working in sort of a high risk area like food handling and preparation, the safest thing is to advise folks to return to work when their symptoms have resolved, when their diarrhea has resolved, and when they have completed their course of Bactrim. So that is sort of general safe guidance, but your state or your local jurisdiction may have other guidance or other thoughts. So I would check with them first.
Great. All right, can we have poll number 3?
Sure thing, launching now. And also, just for, do you want me to ask question and answers or wait until the end for y'all?
Speakers, do you prefer to have some questions in the middle, or would you want to get them at the end?
I love questions anytime.
We'll
Great.
wait for this poll.
This was a big question on this poll, sorry. And with it in both languages, it's a very long set of questions.
All right. We'll wait for a couple more. We got 37%. But while that's going then, somebody asked regarding uninsured and may not be able to afford testing, but have the symptoms. Would you recommend empiric treatment if not contradictions? Contradictions. Yes. Does that make sense?
Yeah, I can take part of that question. Please feel free to hop in, Dr. Bagdasarian, if you would like to. So I think what I would first try to encourage is, especially for those of you who are working in communities, and many of you on this call maybe are in federally qualified community health centers or community health workers, is I think it's important for us to try to really establish trust with community members. And so I think it's important to try to encourage patients and community members to come forward for testing. And I think that simply by speaking somebody's language and telling them this is a clinic that really cares about you and is willing to see anybody, and they'll work with you on paying for the visit and paying for the medications. FQHCs are experts at really meeting patients where they're at and having sliding scales, and if needed, covering cost of certain medications because we have 340B pharmacies. And so my first piece of advice would be is if you're out in the community, please encourage people to find a trusted community health center, clinic, provider so that they can get tested, because I think it is important for people to know what they have. And then it really helps in terms of our being able to really get to the bottom of where the sources of the infections. But to your second question, if somebody if coming into the clinic is really prohibitive because transportation, or there's not a close clinic or cost, then I think it would be appropriate to do empiric treatment. But it'd be important to obviously consult with the provider, and patient would need a good clinical history to really hone down on those symptoms, ensure that the patient doesn't have any allergies. We have to remember that when we prescribe any kind of medicine, especially antibiotics, we need to take a good history on allergies and know about people's renal function. Sometimes we just give people antibiotics without knowing that people have medical problems that could really put them at risk from side effects from antibiotics. So we just have to be really careful with that.
Thank you. And I'll end the poll now. I was hoping we'd get to at least 50%, but we almost got there. There are the results.
All right, so it looks like between health department staff who maybe aren't normally involved in infectious disease, and then clinics, community health centers also generally have not participated in this kind of work. And under an unusual situation like this, you could be called into it unexpectedly. So this is where I will reiterate the importance of building those relationships with your local health department or state health department, depending how your state is set up. And the other way around, right, for local and state health departments to reach out and start building relationships with community health centers, in particular those that are in further out in rural areas where it is really hard for people to find another place for services. All right. So this question is for both of you, and I'll start with Dr. Bagdasarian. What prevention messages, and you kind of got at this, but maybe you want to dig in, what prevention messages should clinicians share when the source of the outbreak isn't fully identified and may be a variety of things at this time?
I can tell you the advice we're giving to people here in Michigan. And again, this advice may vary a little bit based on where in the country you live and what patterns they are seeing and what your public health department has said to you. But here in Michigan, we are seeing again that really strong signal around lettuce. And so we are telling people to focus on lettuce when it comes to their prevention measures. So the safest way to consume lettuce right now is to avoid bagged lettuce or those pre-made salad kits, and instead to buy whole heads of lettuce or salad greens and to physically remove those outer layers that can sometimes be contaminated before washing and serving that lettuce. But for other types of produce, which again, we haven't completely eliminated other types of produce, the safest way to eat other produce is peel it and cook it if you can. And particularly, we've been giving advice around produce that has been linked to outbreaks in the past. And those have been raspberries, cilantro, basil, onions, and snow peas. So we know that they have had, and green onions as well. We know that there have been outbreaks around those things in the past. And so we're advising people to just take precautions as much as they can, including when they are going out to eat. We know that the producers that provide these vegetables to different places, they're supplying restaurants and fast food chains and grocery stores. And so if you are going out to eat, it's a good idea right now, if your state is also seeing a lot of cases, to ask them how they are handling their lettuce, for example.
And Dr. Galvez, is there anything, thinking about really, in particular, the communities that you have worked most closely with and community health workers, is there messages that you think would be best for them or how they might explain things to folks and thinking about health literacy and all that?
Mhm, mhm. So, community health workers are just a vital partner in really containing this outbreak, because there's trust, right? Community health workers share lived experiences with the community. And as I mentioned earlier, oftentimes our immigrant and farm worker communities are really isolated and oftentimes are not getting the information as quickly as other people are in, the local newspaper and the local radio. And so I think the first thing community health workers can do is just truly, really go out into the communities and build those relationships, which oftentimes they already have because they're community members, and just talk about this outbreak and have conversations. I think that it's always I'm always so impressed with so much that our community does already have so much knowledge around like standard precautions in hand washing. So, really going out and reinforcing those practices. Also, I think this is the time where we do need to have some really good information that's in the languages that our community members speak that are culturally tailored about this particular parasite because it is very specific, right? And so we need to make sure that we have those and that we're disseminating that. And then I think this is the time when we're talking about I'm a huge fan of our cultural traditions and practices. And so I tell people that yes, this might be the time that we will be, avoiding those bagged salads. But this is a time where let's think about our ancestors. And if you used to garden and you have a garden, most likely your garden is not going to have the cyclospora spores. So let's think about supporting our local farmers market. And like I said, for so many of our patients who have these gardens, in behind their homes because it's connection to roots back home. Let's eat those fruits and vegetables. Those should be okay. Um, so reminding them that there's other ways to consume fruits and vegetables that we don't have to necessarily go to the store. We don't have to buy the pre-bagged. Um, and then finally, if I have some of my diabetic patients or young kids will say, well, that means I don't need to eat vegetables for a few months. And I say, well, even if you decide that the risk to eat, raw fruits and vegetables is too much, let's remember that we can also, this is a time where we're going to eat other things that have the same similar nutritional content our beans, our garbanzos, our squash. I talked to them about those calabacitas that they like to eat at home. And so just really finding alternative ways to make sure that they're still eating healthy and also thinking about what are those practices that we had back in our home countries when we couldn't go to the grocery store, right? We grew our fruits and vegetables. And so maybe just taking and leveraging that during this time and really showing our strengths as a community. Yeah.
Thank you for that. All right, I see we have a question in the Q&A. Elizabeth, do you want to let us know what are we getting asked?
Yeah, we have what if a person exhibits all these signs and symptoms but does not seek treatment due to all the numerous reasons you have already discussed so far?
I
Dr.
can,
Bagdasarian, do you,
sure.
please do.
For most people with a healthy immune system, cyclospora or cyclosporiasis will eventually run its course, but it can take weeks. It can take many weeks for it to run its course. And so we much prefer that folks get treated with Bactrim because it can shorten the duration of symptoms significantly. And, we here in Michigan with our 7,000 patients have seen close to 150 patients get hospitalized for things like dehydration. So it is something that, while it's not typically life-threatening, it can lead to complications, especially for folks who are dealing with heat waves and who are outside in this type of summer weather. So, I would encourage folks when they can to, if testing is cost prohibitive or if there are other issues around testing that make it difficult, I would encourage at least empiric treatment if you are in a state that is experiencing very high rates of cyclosporiasis and if clinically it seems like it could be cyclosporiasis because you could save somebody weeks of symptoms.
Thank you. There's another question. I will direct it to Doctora Galvez. Are there any potential occupational risk for farm workers who are on the front lines of our food supply? And then a second follow-up question. While we still don't know the precise source, is there any advice or precautions for farm workers in the workplace?
That's an excellent question. I think this person was reading my mind. One of the things that I worry about with things like cyclosporiasis is that we know that uh, any kind of infectious disease can definitely be spread more easily in people who live like in closed quarters or people who travel together, who work together. And as many of you know, many of our farm workers often are traveling together to follow the crops. You know, I'm in Oregon right now, and actually yesterday I was at a farm worker outreach event where we had a group of patients who came from Mexico, and they traveled together, and they're living in one house. There's like 25 people living in one house. We also have families who travel together. And even if they're not traveling together or they're living together, but they're often, working, they're using, for many of you who may not be familiar with the way the fields are, oftentimes there's one hand washing station that is really far from your work site. And so it just becomes a chore to have to always remember to, hand washing is something that we take for granted because we work in areas where we can just walk 2 steps to the next bathroom. But for our farm workers, we talk a lot about the hand washing, but it could mean, you didn't pick that bucket of berries or, because you had to walk to another site, or sometimes, some of these bathrooms don't have running water. And so our farm workers are definitely a lot more, I think they're at higher risk for any of these infectious diseases. And so this is where I think the education is important. And then talking about the standard precautions, which is, even a step back is just that hand washing, right? Frequent hand washing is going to be important. Um, in terms of risk to them, I think I'm interpreting the question as being, are there any extra risks to them? And I don't think Dr. Bagdasarian can correct me if I'm wrong, come from necessarily working with the crops, although potentially, I guess if you're picking the crops and you didn't get to wash your hands before lunch, then you can ingest the oocyte. But it goes back to just really these living in these closed quarters, and yeah. So I had another thought about that, and it just kind of, I am not thinking about it right now, but I would just say those are the big risks. And remembering that when farm workers do get sick, it's always important to understand that many of them have underlying chronic health conditions that we're not aware of. And so we may assume that they're not immunocompromised, but actually they are. I had 2 patients yesterday with A1Cs of 11 who did not know they were diabetics. And these are patients that are coming to us telling us that they're healthy. So just always remembering to keep that in mind. Just because people feel good and they're saying they're healthy, that might not be the case. So we really need to just take extra precautions and always have that extra, um, I guess, care for our farm worker and immigrant patients.
And I just want to take a step back to the earlier part of the conversation too, and thinking about, at least in the areas that have been the most affected right now, and that there may be large companies that are processing tons of lettuce and other fruits and vegetables. And once something gets in that system, and how did it get in the system? It's not like a single person just happened to contaminate something. It could be the whole water system with, whether it's a septic system that's leaking into a water source or some other way that it's getting contaminated and it gets put out in a field and the whole field, then, so thinking about just, don't be thinking that you just need to avoid one particular restaurant, that these things can go wide and far when there's a humongous vendor and producer of certain products like these. And that's sort of what we're seeing, right? So there's so many things that are happening in the background and even delays now of getting information out too. There's been many, changes in our systems of how these things would have been processed in the past. And that are lagging behind because of a shortage of staff and things like that. So there's so many things that are feeding into this problem and making it as large as it is and not stopping it sooner. So that was just 2 cents of mine to throw in. Is there anything you wanted to say, Dr. B, before we move on?
Nope, I think you summarized some of the obstacles pretty well.
All right. So the last thing then, what is the one thing you want every community health center clinician to remember about Cyclospora? If there's just one really key thing you want to say.
Dr. B.
Okay, I can go first. I will just say the one thing to remind folks is that this is not something that is picked up on typical stool, ova, and parasite testing. I think you think parasite, and so folks may be inclined to order the ova and parasite, and those are not the best tests for detecting this. So that's just my one little reminder.
And mine is similar. It's clinicians keep it on your differential diagnosis when you have a patient coming in with diarrhea. And it doesn't have to be just the doctor, right? It can be, we have an entire staff that helps medical assistants, nurses, um, community health workers. If a patient mentions diarrhea, even if it's in conversation and they're talking about the other medical issues, be sure that you nudge the clinician that they're seeing because again, you all have such an important role. Sometimes clinicians they get busy, they're focused on maybe chronic health conditions or somebody's failing kidney function or liver disease, and they could also have an infectious disease like cyclosporiasis, and you as a team member can really help make sure that that patient gets the appropriate testing.
Okay, well, I don't see any more questions floating around. I do want to remind our participants that Migrant Clinicians Network manages a system called Health Network, and that is for people who are moving while they're in care, any kind of care. If they need ongoing care, we can get them set up at a new clinic where they're moving to. We can securely move all of their medical records to the new location and support with appointments and things so that they can get settled into care in their new community. I dropped a link for our website to sign people up. There's no cost for the patient, no cost for the clinician. And then that way you can also close out your patient so that they're not lost to follow up as well and know that they're continuing with whatever kind of care it is they might need. Thank you so much for coming on today. Really appreciate your expertise. And good luck. Hopefully, this is almost over for you in Michigan.
Thank you.